Welcome again. Now we will proceed with the next pro-con section of this today's afternoon. That is whether the PFO should be incidental finding of PFO during CABG should be closed or not. For this, the PFO should be closed. Here is Dr. Jatin Narula, who is a consultant cardiac anesthesiologist at Narayana Super Speciality Hospital. He is having several publications and presentations. Also, he is a recipient of IACTA Kabir Award in 2016. He has also the beneficiary for the ICMR International Travel Grant for young non-ICMR scientists. And he has completed his Harold Gunson Fellowship in 2016. And also he is a young awardee for the Young Investigator Certificate in 2016. And his areas of interest are transcatheter future echocardiography. Now over to Dr. Jatin.
Thank you so much, ma'am, for the kind introduction. Good afternoon, everyone. I hope I am audible. I am sharing my screen and I hope it is visible.
Yeah, it is visible.
Yeah, please carry on.
Yeah. So the topic,
slideshow, yeah.
So the topic of this discussion is PFO should be closed in CABG, and I am going to speak in the favor of its closure. The current world population is estimated to be around 8 billion, and almost 25%, that's around 2 billion people, are living with the PFO. PFO per se has not shown to cause stroke. Transesophageal echocardiography is a gold standard for PFO detection, and increasing use of TEE during cardiac surgery has led to an increased incidental PFO detection. Excited cardiac anesthesiologists suddenly announced about the presence of an incidentally detected PFO which was previously missed. How serious is this matter for the surgeon? Some unknown facts on incidental PFO are that the true incidence of intraoperatively detected PFO in cardiac surgery is not known, and its impact on perioperative events and postoperative outcomes is yet to be evaluated. The true incidence of PFO-related complications is yet to be completely evaluated, secondary to low incidence of complications per se, making it difficult to design prospective randomized controlled trials. PFO closure is important. Why? That's primarily because to eliminate the risk of paradoxical embolism. Almost 60,000 strokes per year are cryptogenic in the United States of America. PFO is significantly higher in such patients, and almost 40% of ischemic strokes without an identifiable cause, that is cryptogenic strokes, have an associated PFO. Perioperative stroke is a major complication, and recent data from non-cardiac surgery at the Massachusetts General Hospital, Harvard University, studying the association of preoperatively diagnosed PFO with perioperative ischemic stroke in patients undergoing non-cardiac surgery has recently been published in JAMA in 2018, and it has demonstrated that patients with PFO had an increased risk of ischemic stroke within 30 days of surgery compared with patients without PFO, and those with PFO had much more severe stroke-related neurological deficit. Various physiological threats during CABG, which I will be discussing shortly, increase the vulnerability of patients with PFO to develop paradoxical embolism. Moreover, recent trials in patients with cryptogenic stroke favor device closure for secondary prevention of stroke based upon their ROPE score, which has decreased the controversy surrounding the management of PFO per se. Another critical issue is hypoxia during right-to-left shunting, which happens when the RA pressure goes much above the LA pressure. And this is very frequently seen during off-pump CABG, and which is secondary to cardiac positioning, mechanical ventilation, high intrathoracic pressures in patients who have pulmonary embolism, right ventricular failure, tricuspid regurgitation, or cardiac tamponade. And it may also be associated with increase in intra-abdominal pressure or altered anatomical relationship between IVC and IAS. Numerous case reports have also been published on hypoxia during off-pump CABG and have made it a cause of concern. So intraoperative decision-making is a challenge, whereas closure changes the surgical plan and subjects the patient to some additional risks. Non-closure exposes the patients to immediate long-term consequences. This decision needs to be made very quickly, with a very short, often without the opportunity to discuss the issue with patient, family, or cardiologist. The advantage of closing it is, yes, of course, permanent closure of the defect, eliminating the risk of paradoxical embolism and hypoxia, with no added risk of anticoagulation. What could be the disadvantages? Possibly nil, maybe the use of extra couple of sutures and maybe a few minutes on pump for someone already on pump. Maybe a few additional risks in those who are going for off-pump CABG. These additional risks are determined by the magnitude of procedural deviation, which is represented by the addition of PFO closure and the status of the patient per se. This deviation is minimal for anyone who's already going procedure running on cardiopulmonary bypass and bicaval cannulation, like associated mitral or tricuspid valve surgery. So incremental risk of closing of PFO in such patients is negligible and it must be closed. The deviation is slightly substantial for those undergoing procedures not requiring bicaval cannulation, but anyways, a planned operation involves cardiopulmonary bypass like aortic valve replacement or on-pump cardiac surgery. And so only minor change of cannulation strategy is required. Small risk of altering the cannulation scheme and slight prolonging the bypass time is outweighed by the chance that a cryptogenic stroke will be averted perioperatively or thereafter. The deviation is, however, markedly substantial, involving complete change in cannulation scheme for patients without CPBs, which is the subject of big debate, and requiring institution of extracorporeal support, making decision-making in such patients totally dependent on patient characteristics. So in such situations, we need to identify individuals at risk and identify patients with symptomatic PFO. And those with history of stroke with a large PFO, IAS aneurysm, pulmonary embolism, pulmonary hypertension, RV failure must undergo a closure of the hole. Probably under evaluation are patients with chronic migraine. However, we do need to review individuals with high risk of CPB-induced complications like severe aortic calcification, hit with thrombosis, severe cardio and renal insufficiency, and contraindications to cardiopulmonary bypass. So is there a recommendation? Yes, published in as a core review in the Anesthesia Analgesia in 2007 by Sukernik et al., who have recommended that procedures with high risk of perioperative hypoxia, that LVAD and heart transplant, the PFO should always be closed, and procedures with atriotomy like mitral or tricuspid valve surgery, it is closed in most cases. Whereas other cardiac procedures like aortic valve surgery and CABG, it is closed when the risk is increased, as I have just mentioned. So is there a scope for research? Yes, in this era of medical legal issues, we need to identify PFOs which are attributable or stroke and hypoxia. Probably adapt the ROPE score to cardiac surgery settings and help to stratify the causal relationship of PFO to stroke. The scoring systems maybe need to be developed to objectively determine PFOs that are likely to trouble. To conclude, it is fair to assume that addition of a PFO closure in a patient already undergoing CABG with CPB should result in very small incremental risk. PFO closure in selected patients appears to be effective in preventing stroke and hypoxia, which should be reflected in the guidelines. Decision to leave a PFO should be carefully weighed, and decision-making in high-risk patients who comprise a small proportion of all patients having cardiac surgery must be individualized. So as a last slide and last comment, I would like to say that PFO is generally benign in off-pump coronary artery bypass grafting until it isn't. And we need to accurately identify and act upon accordingly. Thank you.
Yeah. Thank you, Dr. Jitin. I think Dr. Jikisha will introduce the next speaker.
You can answer, Dr. Jatin.
I stopped sharing.
Yeah. Okay. Thank you. Now I would like to invite Dr. Naresh. We will talk his view about this PFO need not to be closed during the CABG. Dr. Naresh Kumar, he's a MD anesthesiology and done PDCC in cardiac anesthesia, and he's working at Coimbatore, and he's consultant cardiac anesthesiology at GKNB Hospital. So he's having special interest in transesophageal echocardiography, minimal invasive cardiac surgeries, and ECMO. Dr. Naresh Kumar, you can start your talk.
Thank you. Thank you for the introduction. I'm sharing the screen.
Can you share your screen?
It seems, sir. Hello.
You can continue.
Okay. So good afternoon, everyone. So I'm going to speak on all PFOs need not be closed during CABG. PFOs are common benign finding in healthy subjects. Prevalence is high in patients with stroke of unclear cause. At least 1/3 of PFOs discovered are incidental, and most cases it is of unclear clinical significance. Then why are we worried about a PFO? Because PFO is believed to be associated with stroke through paradoxical embolism, although there is only paucity of evidence supporting that claim. And with increasing use of TEE during cardiac surgical operations, presence of PFO is being detected more frequently. And going ahead and closing of all incidental PFOs, which is of clinical insignificance, would expose patients to procedure and device-related risks while leaving the actual cause of stroke unaddressed. So this has left many questions unanswered. When a PFO repair is appropriate, and what should we do if we incidentally diagnose a PFO in an asymptomatic patient on table? So let us get the answers from the literature. This is a paper from Dr. Michael Renziano, which was published in Anesthesia and Analgesia in 2007. Here the author says, for a patient undergoing procedure already requiring CPB with single or bicaval cannulation, the deviation is going to be minimal and the incremental risk is negligible. But for the procedures done without CPB, like in off-pump procedures, like in patients with heparin-induced thrombocytopenia, like in patients with renal insufficiency, or a full aorta is calcified where you'll be doubtful to cannulate, the deviation of plan is going to be significant and the risk of post-operative complication is going to be high. So he says, the change from a planned procedure to include PFO closure increases the risk of post-operative stroke with no long-term benefit. This is another article from Michael Sukarnik et al., which was again published in Anesthesia and Analgesia in 2007. He says that it appears to be prudent to repair when almost no alteration in the surgical plan would be needed to perform this procedure. He also says PFO should be closed when development of significant right to left shunt after surgery is expected, that is during LVAD placement or during heart transplant procedures. This article by Dr. Frank from Anesthesia and Analgesia journal, here the author says that the intraoperative situation of an incidentally diagnosed PFO is fundamentally different because those patients will not have a previous risk of a cryptogenic stroke or a TIA. And these patients will be in the age range in which other sources of embolism, such as atherosclerosis, atrial fibrillation, or carotid artery disease, far more outweighs the risk of a PFO causing embolism. And he also goes ahead and says, as long as the atriotomy is being performed, it seems reasonable to close an incidental PFO. On the other hand, he says there is no compelling reason to go and search for it systematically and to close it for every patient going on bypass. This study, Goel et al., compared PFO morphology between 58 patients. And he found, he compared PFO morphology between 58 patients with cryptogenic stroke and 58 asymptomatic patients with PFO. And from this study, he says that patients with cryptogenic stroke had a significantly larger PFO with a longer tunnel and a greater frequency of association of atrial septal aneurysm with it. This is the last study from Dr. Richard Karuski, which was published in JAMA 2009. This author retrospectively analyzed about 13,000 patients who underwent cardiac surgery at Cleveland Clinic and found about around 2,277 patients were found to have a PFO, of whom 639 went on to have a repair. From the data which he collected, he said that patients undergoing PFO repair were exposed to a longer CPB run, and these patients who had a PFO closure have a 2.47 times greater odds of having an in-hospital stroke, and long-term survival and long-term mortality appears to be similar. And he concludes the study by saying there is no clear benefit of closure on short-term outcome or long-term mortality, and the finding that repair may increase the post-operative stroke risk should discourage surgeons to routinely close a PFO. So what should we do now when we find an incidental PFO on an asymptomatic or clinically insignificant patient? So this is the final article which was published in Cardiology Journal by Dr. Mohammed Abdul Ghani in 2019. He goes ahead and says, younger patients with cryptogenic stroke have a 2.3-fold increased relative risk of having a PFO and 73% likelihood that PFO is the mechanism of stroke in those patients. PFOs with complex morphology are more likely to be associated with cryptogenic stroke. He emphasizes the importance of using ROPE score, that is the risk of paradoxical embolism score, to weigh the risk versus benefit ratio on going ahead and closing a PFO. So the total score comes to 10. This ROPE score takes in account the hypertension, history of hypertension, diabetes, stroke, TIA, imaging parameters, and age into account. The cutoff score is 7. When the score is more than 7, the author says, when the score is more than 7, the author says the stroke is definitely because of PFO, and there is no, and you can go ahead and close the PFO. But when the score is less than 6, the author says the stroke is because of some other reason and definitely not because of PFO, and we have to rule out other causes of stroke. And in a patient with lower ROPE score, that is less than 6, recurrent cerebrovascular events are more likely observed even after a PFO closure. So he says it is not only important to identify patients with the PFO or PFO attributable embolism, but it is also important to identify those patients who are at risk of developing a recurrence. So he says that there are certain group of patients who would benefit from a PFO closure. Who are those category of patients? Younger patients who have a history of previous TIA or stroke, the patients with larger PFO, patients with PFO with a complex morphology that is associated with atrial septal aneurysm, who have a thick septum secundum, etc. And by imaging studies, these young patients who have a superficial cortical infarct are known to be caused by a embolic stroke. So those kind of patients, and those patients who have a documented hypercoagulable state along with PFO. So only these group of patients will benefit from PFO closure. So there is no wrong in going ahead and closing PFO in these group of patients. So to conclude the talk, I say in patients who had a cryptogenic stroke, neither the embolic nature of a neurological event nor the absence of other potential sources are clear, and only the bleak perspective of a repeat event justifies a procedure of unclear benefit and finite risk. There is no evidence to suggest incidental PFO is linked to mortality or morbidity. It can be closed when no alteration of surgical plan is needed to perform the procedure, and it is very important to underline the importance of patient selection for a PFO closure. Thank you.
Thank you, Doctor. So, Dr. Jitin, do you want to say something?
I think Dr. Naresh and a few studies that have been pointed out also have evaluated upon the ROPE score being the key decision maker about determining the PFOs that are attributable to closure. And even if it requires a change of surgical plan, we need to determine which PFOs are likely to trouble, which PFOs are likely to cause a stroke, and then maybe to convince the surgeon, as I can see a question also coming up regarding how to convince the surgeon. Yes, TEE is our guide. TEE will show us, whether there is a large PFO which is associated with any septal aneurysm, and of course to determine whether there is use the rope score to determine whether that PFO could be attributed to the development of a stroke in future, then guide the surgeon to go ahead with a closure, is what I would like to comment.
Are there any questions?
Yes, ma'am. There are 2-3 questions. Anyone can answer, both candidate can give. Is there a difference if CABG is done on CPB or off cap? So anybody can answer either of two. If patient is having beating CABG or off pump CABG, whether a decision is changing with that condition or decision should be changed.
The decision should be made according to the size of the PFO. If the PFO has a complex morphology, in clinically insignificant PFO with a small size PFO, when the RV is not dilated, and when there is no history of previous TAA or stroke, I think it's safer to do it off pump than going in on pump and producing a new complication. If at all the surgical decision is different, then it's going to be different.
Okay, if you are going to do a CABG in those type of patients who doesn't have a complication in the PFO,
yes, sir.
But you are going to do on pump, will your decision change?
The decision will change according to my TE findings. I will inject, I will do a bubble study, and if there is going to be a larger shunt, and if the PFO size is larger, and if it's associated with the atrial septal aneurysm, so these things would suggest me to tell the surgeon to go ahead and repair a PFO.
Okay.
Yes, sir. Not otherwise. It depends on the TE finding.
There is another question. Patient with moderate PH, EF 30%, where surgery is done op cap with no history of stroke. Should we go ahead with the closure of incidental PFO?
The PFO again, is it shunting large? Definitely, if the if the RV is dilated and the PA pressures are going to be high, then definitely we recommend to go ahead and close the PFO, because if the RV failure develops, then it's going to shunt from right to left. So we don't want that in the post-operative period.
Already moderate pH is there, and if any complication post-operative, if any pericardial collection or like that happens, it will aggravate and shunt will be of right to left, and paradoxical embolism chances are high.
Yes.
So
then we are supposed to take the patient to, at least if not to the surgery, then to the cath lab for closing. So go ahead and close for the first time, and then.
Yeah, this is.
And one to be whether there is at the same time, of course, as I had mentioned, that if there are associated high risks of going on bypass, I would like to go ahead with the suggestion of Dr. Naresh that we can maybe do it in the cath lab and as or as an integrated procedure, if the risk of the bypass is too high.
If at all patient is having high risk calcification of the aorta and going on bypass is more harmful, then we can just do the CABG off cap, and then we can go in the cath lab and close the, if larger size or any high risk PFO is there, as you said, aneurysmal septum, or if is a preoperative finding sometimes in the transthoracic echocardiography also, if PFO is like, then also. And one more last question, younger the patient, more benefit from closure, Dr. Jatin?
Yes, ma'am. So this completely brings about the rope score significance, because younger patients have a higher attributable chances of stroke being due to the PFO rather than being any other cause like atherosclerosis or hypertension or diabetes. So yes, if it is a younger patient, we should prefer.
Okay, our time is up. So,
time is up. Yeah. Time is up now.
Rajiv, can you
conclude the session?
Please? So to to close or not to close, it should be on the patient-to-patient basis. You have to see the risk assessment according to the ROP score, and also the surgeon's what is his choice, whether he is ready to go on pump or whether he wants to close this PFO in the cath lab. So it will depend on case-to-case basis. We have to take.
One comment I'd like to make is that as anesthesiologists, we should always try to identify whether it is present or not. And that is more of our job, and we must do that. Right, thank you so much. We'll like to close the session now.
Thank
you for being with
us. Thank you, everyone.
Thank you, everyone.
Thank you.
Thank you, moderators.
Many thanks to Dr. Rajiv Juneja, all the speakers and the moderators. It was indeed a stiff competition, but the battle is not over yet. We do have 2 more to come. For now, we'll take a short break and be back very soon. Stay in touch. Thank you.